Well, good afternoon, everyone. Welcome to the Columbia Doctors Education Series. I'm Dr. Joshua Weintraub, I'm professor of radiology and surgery at Columbia University Irving Medical Center. In addition, I'm the executive vice chairman and director of interventional radiology at New York Presbyterian Columbia campus. Thank you for taking time out of your busy schedule today to learn about uterine fibroids. I'm going to make this relatively quick. I want to try to attempt to make it interactive, even though we are over Facebook and Zoom. But I'm hoping to talk in the next few minutes about uterine fibroids, what they are, how we diagnose them, the symptoms that patients have, and really the treatment options for you. And this is a really interesting topic to me because many medical diseases, we have really set single treatments. But uterine fibroids, there's different treatments for different patients. And we really try to tailor it to the patient, their symptoms, their needs. And hopefully you'll learn more about that in the next 15 to 20 minutes. So the first question really is, what are uterine fibroids? And fibroids are benign tumors that develop within the wall of the uterus. These are not cancers. They're really the smooth muscle of the uterus itself, just getting aligned in abnormal ways. They tend to occur within the wall of the uterus itself, maybe within the central portion of the uterus. These are often referred to as myomas or leiomyomas. And it's really important to realize that these are not cancers. They don't spread to other parts of the bodies, but despite that, they can cause problems due to the vascularity of them, the blood vessels supplying them, due to the size of them, or their location. So this is an illustration from Frank Netter. He's really one of the foremost medical editors ever in the world, and he makes these beautiful drawings. So here we can see the uterus and the fibroids. These fibroids can occur within the cavity of the uterus. So you could see how these could affect pregnancy and often are associated with infertility. They can occur within the wall of the uterus, making the uterus very large. And because of their vascularity and the lining of the uterus, can cause very heavy menstrual periods. Or they can occur on the outside of the uterus, being pedunculated even, like on this little stalk here, or just bulging out in the uterus. And this is a gross pathologic specimen of a patient who had a hysterectomy. And here you can see the fibroids within the cavity of the uterus, extending beyond the wall of the uterus. And really, here's even a pedunculated one off to the side of the uterus. So how common are these? It's really interesting. Up to about 50% of women eventually develop fibroids. The fortunate thing, though, is even though these occur, the vast majority of patients are asymptomatic. Only about 10 to 30% of patients develop symptoms and need treatment for fibroids. And because of this, this is really the most frequent indication for hysterectomy in the United States, with over 600,000 hysterectomies being performed related to fibroids. It's really amazing that a third of all hysterectomies are due to fibroids themselves. So the question really becomes is, are you at risk for these? Who gets these and what causes them? And it's interesting, fibroids occur in women predominantly in the ages of 30 to 50. And these are the years that women are having careers and are out about, children, families, and they can really affect daily life. Black women develop fibroids more often. They often have larger fibroids and tend to have more symptoms. It's estimated that Black women have fibroids 3 times higher than Caucasians. There is a genetic predisposition to this. So this is one of those things that you can blame your mother for. Fibroids tend to occur in families. It's often interesting when I see a patient, they'll say, you know, my sister had a hysterectomy for fibroids and I don't want a hysterectomy, and that's why I'm coming to see you. You know, my mother had fibroids and complained about these her entire life and never did anything about them. There is a linkage to progesterone and estrogen. So often during menstrual periods, fibroids may enlarge and grow during those times. So patients may see more symptoms from fibroids during menses. They may regress, and they often grow with time. But despite all this, this is one of those things that medicine, we really don't know exactly what causes them. As I was saying, fibroids do tend to have a racial dominance in Black women, about 3 times more frequent. So despite having fibroids, it's really when patients have symptoms related to fibroids that we want to do something about them. You know, as I tell my patients, if it's not broke, don't fix it. These are benign. But when patients start to have symptoms that affect daily life, that's really when we want to intervene. And I really divide the symptoms into two groups. One is due to the vascularity of the fibroids. Patients will often have very heavy menstrual periods. The menstrual period may be very long, lasting 10 to 14 days, extraordinarily heavy. I had one patient whose menstrual periods were so heavy that she was changing menstrual pads every hour. In addition, patients may become anemic because of these, may need to have iron supplementation because of the significant blood loss that they may have from menses. The other thing that patients often have is what's called menometrorrhagia. So in addition to having a menstrual period, they may have bleeding in between, spotting in between the menstrual period. The other thing that fibroids can cause is bulk-related symptoms due to the size of the fibroids. And you can see on this diagram here, you may have fibroids that are compressing the bladder and pushing into the bladder. They may be causing abdominal wall distension, or even sitting on the back of the uterus. I had one patient who had very severe sciatic pain because the fibroid was sitting right against her sacrum, and really that back pain was entirely due to the fibroids. And after treatment, her pain resolved. It's important always to remember that just because you have fibroids, they may not be the cause of your pain. And so part of the entire evaluation really makes sure that the fibroids are the cause of the symptoms that you're having. There are other things that cause heavy menstrual periods, and the main things that we worry about would be endometrial problems, such as a disease called adenomyosis, where you have abnormal growth of the lining of the uterus into the wall of the uterus, or even some types of cancers that can cause this. We want to make sure we exclude all those and make sure that the fibroids are the reasons for your symptoms. So what if I don't have symptoms? You're one of those fortunate patients who really may just have fibroids. You're part of 50% of all women. And obviously, we're not operating on 50% of the female population. But how do we diagnose the fibroids when you have them and make sure that that's the cause? And all of our patients are seen in consultation. We talk with you, we go over your history. We always make sure that you have a gynecologist involved, and we really have a team effort when we approach fibroids. Many of the fibroids can be diagnosed on your routine gynecologic exam by a bimanual exam and the gynecologist palpating and feeling the size of the fibroids in addition to the symptoms that you're having. And often we'll do an abdominal ultrasound or even an MRI to get an idea of the fibroids, the vascularity of the fibroids, and their pressure on adjacent organs. Pardon me for 1 second while I just have a quick sip here. I'm getting to do all the talking this afternoon while you guys get to listen. So that's really how we diagnose fibroids. This is my partner, Dr. Reese. As you can tell, I'm the good-looking one in the practice, but I have several partners. There are 7 of us total, and they're all absolutely wonderful. I would trust any of my family members with them. They're really some of the best physicians I've had the pleasure to work with. So how are uterine fibroids treated? Fortunately, most fibroids don't cause symptoms, don't need treatment. But when patients have symptomatic fibroids, the treatment's really tailored based on your age, your general health, the severity of the symptoms you're having, and even the type of fibroids, whether a pedunculated fibroid or an intrauterine fibroid, and also your desire for a future pregnancy. And I know that's an issue for a lot of young women, and we'll talk a little bit more about that when we get to the question and answer period. So fortunately, medical therapy is often the first line for this, especially for patients who are having very irregular menstrual periods or heavy menstrual periods due to fibroids. Things as simple as starting oral contraceptives, birth control pills to regulate the menstrual cycle can really help with the bleeding symptoms. They obviously don't do anything for the bulk-related symptoms, but that's usually our first line, is to try to regulate the menstrual periods. There's some other medications, you may have heard of these drugs called Lupron or Megase, which essentially get your body to feel that it's in menopause. And so for patients with bleeding symptoms, it's very effective. You stop having menstrual periods. The fibroids will shrink, but not a lot, usually only about 10% in size. The main challenge with that, however, is the rest of your body thinks it's in menopause too. So you start having menopausal symptoms, including hot flashes, lack of libido, vaginal dryness, and important in Caucasian women, you can get bone mineralization loss, osteoporosis. And so because of that, we don't like using those drugs for more than about 6 months. Sometimes we'll use those when a patient's extremely anemic, just to help them build up their hemoglobin. The challenge with any of the medical therapies is when you stop doing the medical therapy, the fibroids will return in size. And because of that, we've really been exploring a lot of minimally invasive and surgical options for uterine fibroids. As we talked about, hysterectomy is in fact the most common medical surgery done throughout the United States. Over 600,000 hysterectomies done for uterine fibroids. And it's very effective. The uterus is out, the symptoms are gone instantly. You decrease your risk for uterine cancer because the uterus is out. And often they'll do an oophorectomy at the same time, removing the ovaries to decrease your risk for ovarian cancer. So it decreases the risk, it doesn't entirely eliminate it. The challenge with that, obviously, is that you do go into menopause with the ovaries removed, but there's some benefits from that. The major drawbacks are that it's obviously major abdominal surgery. They can do some of these laparoscopically or hysteroscopically, but most of the patients who have large fibroids need an abdominal incision to have the fibroids removed. And so you're looking at a recovery time of 6 to 8 weeks. So for patients who have fibroids, are having very busy lives, it's a long time to recover. In addition, there can be significant blood loss during a hysterectomy. Often they'll have you donate your own blood ahead of the procedure itself. Because of that, more minimally invasive procedures have been developed, including a procedure called myomectomy. So as opposed to removing the entire uterus, in a myomectomy, the gynecologist goes in and removes the individual fibroids. So they may be able to do that hysteroscopically, as you see here, and take the fibroid out, or laparoscopically, where they can go in and remove the fibroid laparoscopically. And with some of the newer techniques, they even go in with a laparoscope and an ultrasound probe and are able to do what's called a radiofrequency ablation, put a needle into the fibroid, and as opposed to removing it, they heat the fibroid and destroy it in place. So this procedure really has been around a long time. It's very effective for young women who may desire future pregnancy. It really has the best data that we see, although uterine fibroid embolization that we'll talk about is coming closer, for patients who want to maintain fertility. The biggest problem is you can only remove the fibroids that you can see. So they're really moving the larger fibroids, the pedunculated fibroids. So there's a very high recurrence rate from myomectomy. Upwards about 30% of women will go on to require another procedure, whether it's another myomectomy or a hysterectomy. One procedure that patients often haven't heard about is a procedure called endometrial ablation. And this is really just directed at patients who have very heavy menses. It's an outpatient procedure done by the gynecologist where they're able to come in through the hysteroscope, through the vaginal canal and cervix, and they essentially inflate a balloon inside the uterine cavity. They then instill very hot saline and essentially scar the entire lining of the uterus so that you don't have any more menses. You obviously can't get pregnant after this. And it doesn't do anything related to the bulk-related symptoms, the size of the fibroid, but it's very effective for patients who having menses is really their only problem. Again, because you can imagine that we're just scarring the lining, this fibroid here will continue to grow. And again, there's about a 10 to 20% recurrence rate from endometrial ablation. By far the most minimally invasive procedure on the list is what's called high-frequency ultrasound, often referred to as HIFU. This is done under an MRI scanner guidance. Patient goes into an MRI scan, and we're able to target dot by dot by dot the fibroid, heating it up with ultrasound waves coming from different sides. No needles, nothing within the MRI. The challenge has been that we're very effective at destroying fibroids. Those ones that are only 3-4 centimeters in size, we're very good at getting those. However, those aren't the ones that are symptomatic. The larger fibroids are very hard to destroy and can take up to 4 or 5 hours within the MRI scanner. Because of that, it hasn't really found its niche in uterine fibroid treatment because of the fact that it hasn't been successful in destroying those larger fibroids. And finally is uterine fibroid embolization. And that's what's done by an interventional radiologist. That's what I do. To treat fibroids, and is really one of the most minimally invasive procedures and is very effective. So I think the first question is, what's an interventional radiologist? Probably most of you have not heard of an interventional radiologist. It was interesting as I went through my training, I did a year of general surgery and then radiology and then interventional radiology. Even my parents asked, what do you do for a living? So interventional radiologists, the best way to sort of describe what we do is we do minimally invasive surgeries using image guidance. So I use ultrasound, CT fluoroscopy to trace my way through the body and to be able to provide different therapies to different parts of the body. Traditionally, we do these things through a little tiny nick. When I do uterine fibroids, I'm able to trace either through the wrist or through the leg. We'll talk a little bit more about that. And do what's a procedure, what's called an embolization. And this has been done by us for over 40 years. We really started out doing this a lot for patients who had bleeding. We were able to get to blood vessels that were bleeding and cut off the blood supply to that. And then the field evolved into cancer therapy, where I go into parts of the body and deposit very high doses of chemotherapy into a tumor or cut off the blood and oxygen to the tumor. And then it evolved to uterine fibroid embolization in the late 1990s. And what we're able to do is really reduce the symptoms that patients are having, both that bleeding and bulk-related symptoms, deprive the fibroids of their oxygen and nutrients, get them to shrink in size, while at the same time preserving fertility, avoiding surgery, and preserving the uterus. So all procedures take a little prep and a little work to get there. As I was saying, we see all of our patients in the office. This is my colleague, Dr. Peter Schlossberg, with a patient. We work very closely with our gynecologist. So all patients do have a gynecologic exam. If you have an existing gynecologist, we work with them. Otherwise, we have a terrific group here at Columbia Doctors. For women over 45, we really want to make sure that the bleeding symptoms that you're having are due to uterine fibroids. And we do recommend an endometrial biopsy to exclude that. And then we get routine preoperative exams and imaging, including an MRI, to see exactly where that fibroid is, the vascularity of that fibroid, the size, and other organs that may be placed on. So this procedure is done, if you can imagine, completely as an outpatient. We have offices down at 51st Street, West 51st Street here in New York City, and up in Tarrytown, right near the Mario Cuomo Bridge. You come in the morning. These are always the first patient, 8 o'clock. And the procedure is done under conscious sedation. So it's twilight sedation is what a lot of patients think of it as. We use 2 medications, Versed, which is a drug a lot like Valium, and it keeps you relaxed. The procedure is really not painful at all. It's really the anxiety that patients have. And I've had patients really do this with absolutely no sedation. And the other drug we use is a drug called fentanyl, which is a lot like morphine, but about 100 times stronger, just in case patients have any pain. We're able to trace either through the wrist all the way out to the uterus or through the groin. And I'm doing more and more of my procedures through the wrist now. It's a tiny little incision. You're able to get up and about afterwards, move fairly quickly. Most patients go home early in the afternoon, 2 or 3 o'clock in the afternoon. We trace out with a tiny catheter. It's not much thicker than a hair to the blood vessels that specifically supply the uterus and the fibroids. And then we put in small little particles. These particles are FDA approved specifically for uterine fibroid embolization. They block the blood flow, the oxygen, the nutrients to the fibroids, causing the fibroids essentially to die, scar down, and be reabsorbed by the body. So this is one of my patients. This was a 32-year-old woman who was having significant urinary frequency. She was going to the bathroom, if you can imagine, just about every 1 to 2 hours. And here you can see on an ultrasound examination, I'll teach you a little bit of ultrasound. This is her uterus here, and this is her bladder, is the black part. And you can see this fibroid indenting into her bladder. It was so large. And so we were able to trace down through her wrist. Here she is resting on the table, awake, comfortable, down through her wrist to these blood vessels here that supply the fibroid. And here you can see the fibroid, the vascularity of that fibroid. We put those little particles in, and just 3 months later, she was having normal menses. She'd gone from very heavy periods. Her bulk-related systems had completely resolved. So here's her MRI before the procedure. You can see these really large fibroids really filling the entire pelvis. Then just 3 months later, it shrunk in size. Her urinary symptoms had resolved. We continue to see shrinkage of those fibroids, the vast majority by 6 months, but they'll continue to shrink all the way out to a year. In terms of post-procedure care, we have private recovery rooms for our patient, and really you go home essentially with a Band-Aid. The most common side effects I see are pain. I wish I could tell you that there were no complications or side effects from a procedure, but patients have a fair amount of pain. The first day, patients sort of describe this as a severe cramp. By the second day, the pain's sort of a moderate pain. Usually patients are up about back to normal activities by about the 3rd to 4th day. I see a lot of patients on Tuesdays and Wednesdays who have an active, busy life. They'll go back to work that Monday, if you can imagine, just a couple of days off from work. It's not unusual to have a fair amount of spotting that first month. Usually that menstrual period is shorter, lasting about 20 days. The second menstrual period is often lengthened out to 35, 36 days. It's usually not until the third menstrual cycle that patients get back to a normal menstrual cycle and really see that significant improvement. The other side effect we worry about is what's called amenorrhea. So this isn't menopause. Patients just stop having menstrual periods. In women under 35, it's extraordinarily rare, less than 1% of patients. But in women over 45, we see that in upwards of about 15 to 20% of our patients. So as I was saying, they just stop having menstrual periods. They don't get symptoms of menopause at all. And nobody's really quite sure what's this due to. We've checked hormonal levels. We don't really see any changes in those. They're just not able to build up enough lining of the uterus itself. We obviously follow all of our patients closely, both with phone calls and with imaging. And now in this day and age, we do a lot with telehealth. It's really been a terrific change in what I do on a daily basis. I often see my patients by telehealth ahead of time in the office. We coordinate that with their MRI if they need it. And we're able to do our telehealth follow-up visits also. So we're often asked, is this procedure experimental? And it's really been well established now in the literature it isn't. There are over 2,500 articles published on uterine fibroid embolization, really in some of the most major journals in the world, including the New England Journal of Medicine, Lancet, which is the equivalent of the New England Journal of Medicine in Great Britain, and multiple studies, both in the OBGYN literature and in the radiology literature, really saying that this is prime time. This is standard of care for patients for uterine fibroids. But as we talked about, it's really that selection of the patients, talking with you, meeting with you, seeing what your goals are, and deciding what therapy is best for you. And that's really what I do in my consultation, is work with you to see what option's best for you. Is it a hysterectomy? Is it a myomectomy? Should there be some other procedure that you undergo? In terms of our results for uterine fibroid embolization, it's highly effective. Technically, we've got this down. 98% of the time, we can treat the uterine fibroids. In terms of patients' treatments, about 90% of patients need no further treatment. For bleeding, we do extraordinarily well. About 90 to 95% of patients go back to our normal menses. You see significant reduction in their menorrhagia. The bulk-related symptoms are harder for patients to describe for me, and similar, it's harder for us to gauge response. We do quality of life surveys on patients. We see about 85% of patients, 85 to 90% of patients, saying that they saw a significant improvement in their bulk-related symptoms. Objectively, when we look at the uterus itself, the overall uterine size decreases somewhere in the neighborhood of about 40 to 60%. Any specific given fibroids decreasing over 75% in size. So we have both objective and subjective measures that we look at. Because as I said at the beginning, the most important part of all of this is the patient's symptoms. When you're symptomatic, that's when we want to treat fibroids. We don't just treat them because they're there. We want to improve your quality of life. So we're sort of getting to the question period, and I figured I'd start with some of the common questions that patients ask me. And then if you want to go on the chat, you guys probably understand that better than me. Go ahead and ask me questions. I'll be here for a while and hopefully have taught you a little bit about uterine fibroids and the treatment options out there. So some of the questions patients ask me often are, will my fibroids totally disappear through my uterine fibroid embolization? And we're not taking the fibroids out. We're really causing them to shrink and the symptoms to improve. So the fibroids do remain there. A lot of them decrease in size. A lot of them go away completely. The fortunate thing about uterine fibroid embolization is we've seen a very low recurrence rate. The recurrence rate of patients having to need it varies in the literature. In one of the most recent studies that came out, the recurrence rate was essentially 0 for 350 patients. But overall in the literature, we see a recurrence rate somewhere in the neighborhood of about 5 to 10%. Can I have children after uterine fibroid embolization? That's probably the most frequent question I get asked and the most complicated question I get asked. For young patients, I really still do recommend patients have myomectomy for a 25-year-old as their first treatment choice for uterine fibroids. It has the longest track record. It's very effective in removing the fibroids, and we know patients can get pregnant afterwards. There have been studies comparing myomectomy to uterine fibroid embolization and showing equal pregnancy rates. In one of the most recent studies I just published this year, 88% of patients under the age of 35 who tried to get pregnant were able to get pregnant after uterine fibroid embolization. That being said, there have also been a couple studies that have shown some lower birth weight in children who've had uterine fibroid embolization, other studies that have shown no difference. So it's a little bit of a complicated question. When I'm talking to a 35-year-old patient or a 40-year-old patient who has 2 kids and says, I want to keep the option out there, but I'm not sure I really want to get pregnant. It wouldn't be a bad thing if it happened. Those patients, we really have a discussion about that. And many of those patients I will do uterine fibroid embolization on. Next question is, will my heavy periods go away after the procedure? And the nice thing about that is that's a resounding yes. We do extraordinarily well with people who are having heavy menstrual periods, with menses. 90 to 95% of those patients see improvements in their heavy menstrual periods. Is the procedure done in a hospital? It's interesting. When I first started doing uterine fibroid embolization, you can imagine, this will give you a little hint as to my age. The first procedure I did was in 1997. And the first paper published on this, in fact, was by a gentleman by the name of Scott Goodwin out in California in 1997. Those patients we kept in the hospital for 2 days. Now all of these procedures are done as outpatients. With the COVID pandemic here in New York City, we've become very conscious of that. And so because of that, we have a lot of social distancing in our outpatient centers. We test all of our patients for COVID prior to the procedure. Procedure is done as the first procedure of the day. Patients have a private recovery room, and the recovery is fairly fast. Most patients are home by 2, 3 in the afternoon. Is UFE, next question on my list, is UFE a safe procedure to schedule during the COVID pandemic? And I would say yes. Now we really have achieved that social distancing. And if it's affecting your daily life, we ran into issues in the middle of the pandemic where we were essentially stopped to ground zero. And now patients really have to get back to activities in daily life. We can't sit in this pandemic forever. We need patients to be treated for their health-related issues. And the final question that I often see asked is, will my insurance pay for uterine fibroid embolization? One of the joys of being an academic is I don't have to worry about billing or any of those things. I get to do my research and I get to treat patients and make them better. So I always argue I've got the best job in the whole world. The nice part from the billing standpoint is our financial people take care of all of that. All major insurance companies recognize uterine fibroid embolization as a treatment for fibroids and do pay for uterine fibroid treatments. So with that, I'm going to go over to Facebook and to see if there's some questions that I can answer for people. So the first question here is, would it be okay to have a UFE after having a myomectomy several years ago? So the answer to that is yes. It's one of the nice things about uterine fibroid embolization is having had a myomectomy previously does not affect your ability to have a UFE. We're targeting the vasculature to the fibroids themselves. And so just because a fibroid has been removed, we still see the vascularity to all the other fibroids. They light up like light bulbs. It's really easy for us to detect them and treat them. One of the good things, interesting things about uterine fibroid embolization is often when I go through the risks and benefits with patients, they'll say, well, it's effective in 90% of patients. What happens if I'm one of those unlucky patients who I don't see the improvement that I want from this? I've got a 25 centimeter fibroid. You're shrinking it down to 10 centimeters, but I'm still feeling that I want it out. You really haven't reduced your options for any other therapies. You can still have a myomectomy after you've had a UFE. You can still go on, obviously, to have a hysterectomy after a UFE. And so it really keeps the doors open for other procedures as you go forward. The second question is, do I need to be seeing a OBGYN at Columbia in order to get a consultation with your practice? The answer is no. We work very well with OBGYNs throughout the area. It's interesting. I went to college up at Harvard, and one of my classmates is an OBGYN up in Westchester County. She's with West Med, and I'm probably going to get her into trouble, but we've been friends for boy, 35 years now. And she still sends me many patients from her group and seeing patients up in Greenwich and throughout Westchester. And so we work well with your OBGYN. That's part of the nice relationship that we have with them. All right. Next question on the Facebook is, can fibroids go away on their own? So it's interesting. Fibroids will go away. The symptoms often go away when patients go into menopause. So sometimes a patient's main complaint may be bleeding and they're getting perimenopausal. And if that's their real complaint, sometimes we'll try Lupron or Megase for 6 months, see if we can reduce the bleedings and the symptoms they're having. And when they go into menopause, the bleeding symptoms may resolve. The bulk-related symptoms are a little bit more complex. Because of the size of those fibroids, fibroids will shrink in menopause. The average reduction is usually somewhere in the neighborhood of about 15 to 30%. So you don't see that large reduction that you do see with uterine fibroid embolization. So I have, in fact, treated some patients who are menopausal or perimenopausal just to try to get the bulk related down more. But menopause does help with the bleeding symptoms. Next question I have here is, how many fibroids can be removed in the embolization procedure? Terrific question. It's really interesting. That's why uterine fibroid embolization has such a low recurrence rate. These fibroids, when we do the arteriogram, and you saw the blood vessels on the picture before, they light up like light bulbs. They are so vascular. We essentially treat every single fibroid in the entire uterus. We're not targeting one or the other. We target all of them. So you see reduction from all the fibroids. All right. You guys have great questions. Is fibroid embolization an experimental procedure? It's interesting. When we first started out, there was a lot of questions about experimental procedures back in the 90s, the early 2000s. In fact, the FDA does not approve procedures. They approve devices. The device we use for this is FDA cleared for use in uterine fibroid embolization. And it's now really considered an accepted procedure by all the major medical organizations, all the OBGYNs, interventional radiology, the AMA, and all the insurance companies. So it's really not experimental at all. Is this procedure appropriate for multiple fibroids over 10? You know, as I was saying, they all light up. We can treat every single fibroid in the uterus. So that's really where this has its strength. If a person has a single isolated fibroid sitting outside the uterus, often that benefits most from a myomectomy. They can take off that single fibroid, clip it, it's gone, the bulk-related symptoms are gone. When patients have multiple fibroids filling the entire uterus, the other procedures don't work as well as uterine fibroid embolization. Next question is, will I have to be put to sleep during the procedure to remove the fibroids? Now, it's interesting. Many patients want to be put to sleep, and you really don't have to be. Really, the only painful part is the lidocaine I use when I get access at the wrist. After that, when we're tracing through the body, you really don't feel anything. Patients will sit there comfortably. I've had some patients who want to sleep more than others, and they'll fall asleep with the Versed and the medications we use. I have other patients who are totally intrigued in what we're doing, awake during the procedure, listening to music and watching it on the screen. So it really varies by patient and what you want. We can keep you as comfortable as you want, but patients do not have to be put to sleep for uterine fibroid embolization. This is always the question patients have. How soon after the procedure can I have sex? So really, it's just limited by you, especially because we're going through the wrist. Patients will feel pretty crummy for a few days afterwards. You know, you'll have a lot of crampy pain for that first day, mild to moderate pain for 2 to 3 days. But after that, you can start having sexual intercourse. It really doesn't affect that. One of the interesting things that people don't talk about is orgasm associated with that. And one of the things that we've seen with hysterectomy is often after hysterectomy, patients will stop having orgasms or have different types of orgasms. There's a thing called a uterine orgasm where patients get complete contraction of the uterus when they're having sexual intercourse. And after hysterectomy, that can be disrupted. We don't see that with uterine fibroid embolization. It's very rare. Only about 1% of patients, 1 to 2%, will notice a change in their orgasm after uterine fibroid embolization. the next question here is, can I explain a bit more what bulk-related symptoms are? So bulk-related symptoms are related to the size of the fibroids. So as you saw in the diagrams, these fibroids can get very large. They can be the size of a grapefruit or even up to the size of a cantaloupe. And they put pressure on adjacent organs, the bulk of the uterus itself. So they'll put pressure on the bladder, and the volume of the bladder can't expand, so you feel like you have to urinate all the time. They'll put pressure on the rectum, and patients can get constipated or obstipated because the stool has difficulty passing the fibroid itself. Patients will get abdominal stench, and they'll look like they're pregnant and have an abdomen sticking out. And I've had some patients ask, can you give me a flat abdomen, doc? And I'm like, well, that's always a challenge. Imagine if you had a flat abdomen before we did uterine fibroid embolization. But patients will see even reduction in those fibroids that are protruding into their abdomen. And finally, if they're protruding backwards, as I talked about my one patient, she had horrendous sciatica from the fibroid putting pressure right on the sciatic nerve deep in the pelvis. And after uterine fibroid embolization, those symptoms started to resolve. Let's see. Does this procedure work for fibroids 7 to 9 centimeters outside the uterus? So it's interesting. For fibroids that have a broad stalk, so if you think about, what's our latest thing? I'm forgetting now. Oh, it'll come to me. It'll come to me in a little bit, sorry. Some fibroids have a very broad stalk and maybe outside the uterus, and those it's very effective from we'll see the fibroid reduce. It's the fibroids that have a very narrow stalk and are sitting outside the uterus. Those sometimes we worry about because they contorse and fall off. And that's why we like to get an MRI to evaluate those first. And many of those are better served by having a myomectomy, a laparoscopic myomectomy, than uterine fibroid embolization. And so that's why a consultation is really important, imaging, knowing exactly what's going on with your fibroids. What's the next procedure? I've had fibroids removed several years ago and they've grown back. Would you recommend treating or removing them if they're not currently causing severe symptoms? So this really gets back to the most important thing. And if you take anything from our talk today, this is really the most important things. Fibroids are benign. They don't metastasize. The chance of fibroid being a malignant fibroid is extraordinarily rare, about 1 in 1,000. We worry about those. Fibroids called a leiomyoma. The malignant ones are called a leiomyosarcoma. And it's very difficult to differentiate those on imaging. And it's really the aggressive fibroid people think that may enlarge. Sometimes they look strange. Sometimes they grow back faster and they don't respond to uterine fibroid embolization. If a fibroid's not causing you symptoms and you're asymptomatic, you really don't need them to be treated. All right, do we have any other questions? Will I get my flat stomach back after UFE? It depends on the symptoms, the fibroids, and what the imaging looks like. So it's definitely challenging. It always still will require a lot of sit-ups to get a flat stomach. I think I've been working on it for years and it still hasn't happened. But the fibroids themselves will shrink in size. As we said, they shrink up to 75% in size. And so if that fibroid's sitting anteriorly, it's 5 centimeters, 10 centimeters in size, that's going to shrink to a 2-3 centimeter fibroid. And so you'll no longer have that protruding anteriorly into your abdomen. All right. Could endometriosis and uterine fibroids appear together? Very good question. Yes. So that's what we get to when we look for the causes of the symptoms that you're having. Endometriosis, adenomyosis, uterine fibroids, endometrial cancer are all in the differential for patients who are having both pelvic pain, bulk-related symptoms, and heavy menstrual periods. And that's why it's very important that we have an examination done and imaging done to look to see what the cause for your symptoms are. I hope that answers the question. Can you explain more about why we do endometrial biopsies for patients over 45? So one of the causes of abnormal bleeding is endometrial carcinoma. Endometrial carcinoma develops more commonly postmenopausal, as that endometrial lining continues to get thicker. Ultrasound evaluation and MRI examination are good when we see a thickened endometrium, that it could be endometrial carcinoma, but endometrial biopsy is by far the best and really is a standard procedure for gynecologists to do for patients who are having abnormal bleeding. In women under the age of 35, it's extraordinarily rare to have endometrial cancer. It's really a cancer of women over the age of 45. And that's why when patients are symptomatic and they have bleeding, we recommend a full exam, including an endometrial biopsy. It's really probably no different than having a routine pap smear for all women. What about the pain level after fibroids are removed? Is it possible to still have a painful menstrual cycle? It's interesting. Uterine fibroids do cause pain. By far, the things that's been shown to be the most effective for patients who have painful menstrual periods, it's often due to the fibroids growing the estrogen and progesterone levels. By far, the most effective thing has been shown to be non-steroidal anti-inflammatories, medications that you think of like Advil and Motrin, right? Those work much better than Tylenol or aspirin for patients who are having very painful menstrual periods. We do see an improvement in the pain that patients are having after uterine fibroid embolization, if that's one of their symptoms. Some patients will continue to have pain, but non-steroidals should help with that. All right. Terrific. Well, I think we're getting back to the end of questions. As I said earlier, all my colleagues are terrific. We'd be happy to see you. We're doing a lot of televisits, telehealth visits these days, which has really changed how I do medicine. It's a wonderful thing being able to talk to patients at their home. We're very obviously cognizant in New York City about COVID. I commend everybody on wearing masks. I've got mine with me at all times. So please wearing masks. Andrew Cuomo's done a good job in New York. We're obviously been beating the curve. It was a tough time for a few months here at Columbia New York Presbyterian. So we do appreciate everybody's support through the COVID pandemic. And want to wish everybody a good day, a healthy weekend. And hopefully, if you have any problems, please call us. We'll be happy to talk more and meet you both either in person or with a televisit. And have a nice weekend. Take care. It's been a pleasure.